Welcome back, guys. I shall now be explaining to you in a case-based scenario ST elevation MI versus non-ST elevation MI, and then we'll compare the treatment as well. At the moment, my patient is 60 years of age. He is a known case of hypertension. Maybe he's non-compliant with this medication and does 2 packets of cigarette every day, though he has been warned by his family members, including me as a physician. General physician of him has told him to stop smoking, but he's still persisting in spite of this. And today morning when he woke up, he started suffering from chest pain. I have already explained to you that vasoconstriction is more in human body in the morning hours. So most of the time, the coronary events usually occur in early morning hours. Even stroke happens more commonly in early morning hours. So this person is having chest pain at rest. Either he can write the word Levine sign, or he can just write chest pain at rest in an individual. The point is, the chest pain will be very oppressive. In fact, in some cases, the pain can be so bad that he can even end up with vasovagal syncope. So this person is putting his whole hand on his chest or fist on the chest to describe the oppressive nature of the pain. And do not be under impression that in coronary artery disease, the pain will only be on the left side of the chest. It can definitely be on the right side also. It will generally be a diffuse pain. Along with this, because of the sympathomimetic stimulation, there's a lot of sweating happening. So though the air conditioning in my casualty is running full blast, this guy is sweating very profusely, and gradually, because pulmonary edema will begin to set in, so this person will start developing breathlessness also. I want you to remember the fact that if a person is breathless, even on, let me say, changing a pair of clothes or even going to the bathroom, which might be 10 steps away, I'm going to call this dyspnea on minimal activity. The minimal activities I explained were changing a pair of clothes or maybe going to the washroom, activities that we don't even think about. So this is technically by New York Heart Association called as grade 3 dyspnea. He might even mention, or the relatives of the patient might mention, that whenever he lies or tries to lie supine, there is worsening of the breathlessness component, that is orthopnea. And in fact, lots of time these patients may never reach the hospital, in a sense that if there's a full-blown left ventricular failure, then there would be a pink frothy sputum. I mean, that's going to be pretty a scary sight for the relatives per se. And these findings that I've written, especially orthopnea, pink frothy sputum, they may or may not be present initially, because if person will come early, then these manifestations of pulmonary edema may or may not be present. So I'm just writing plus minus to highlight the fact that if a person reaches the hospital late, then the chances of heart failure, chances of pulmonary edema component will dramatically increase. Now, once he's inside the casualty, I'm taking good care of this guy. So I'm first checking the vitals and then I'll be evaluating the heart sounds. I notice that the heart rate of this guy is fairly fast. Let me say 130, 140, which is disproportionately fast considering his age and that he's sitting on a stretcher or on a chair. The blood pressure of this guy is elevated. Why? Because of sympathomimetic stimulation, and the neck veins of the patient are full. So either he will write the word full neck veins, or he might write the word elevated JVP. And I've already explained to you the fact that normally the jugular venous pressure tends to fall with inspiration. Whenever we take a deep breath, the JVP tends to fall. But in this person, I'm noticing that the column of JVP is not falling with respiration, and that would be referred to as Kussmaul sign. Kussmaul sign has been discussed even for constrictive pericarditis. It is also present in patients who would be having restrictive cardiomyopathy and right-sided myocardial infarction. At the moment, I do not know whether it is an anterior wall MI or whether it is going to be a posterior wall or an inferior wall MI. That obviously ECG will tell me, because in part 1 of acute coronary syndrome, I have taught you about infarct localization. Now, once the vitals tell me that there is a gross problem with the heart of this guy, I put my stethoscope and I noticed that S1 was relatively louder. That's because of sympathomimetic stimulation. And then I decided to evaluate for second heart sound. Now, second heart sound is of fair amount of importance in all multiple choice questions, because it tells you that which side of the heart is involved. Like I have highlighted A2 and P2. You are very much familiar that normally the gap between A2 and P2 is approximately 30 milliseconds, which we call as splitting. And this is a physiological splitting that is present in all of us. This splitting is best heard at Ebb's point. The location of Ebb's point would be on the third intercostal space on the left hand side. Now, my point is, if this person is having left ventricular failure, if left ventricle will not work properly, it will take more time for the blood to go out of the heart. And if the blood will take more time to go out of the heart, then aortic valve will close late. If the aortic valve will close late, I'm just shifting this A2 closer to P2 to highlight the fact that if you hear or if you read in a multiple choice question, narrow splitting of second heart sound, it always tells you that there is a left ventricle failure that could be occurring in the patient. On the other hand, if you read a MCQ that is rather telling you same kind of history given, but he's talking about wide split second heart sound, then he's talking about right ventricular failure. So splitting of second heart sound, whenever the examiner will give, he basically wants to see that can you pick up the side of the heart getting involved. Like if it is a narrow split, then I know at the back of my mind that probably in this person, left anterior descending artery is the one that is hampered. Now I changed the side of my stethoscope. Initially I was using the diaphragm. Now I'm using the bell. And when I hear with the bell, I could hear a third heart sound also. The technical term that might be written here is called as ventricular gallop rhythm, and this tells you about development of heart failure. Now, if person comes early, it may not be present, but my point is that if you're hearing a third heart sound, that is obviously a side of concern, or I would say auscultatory finding of concern, and third heart sound cannot differentiate whether left side is involved or right side is involved. So if you want to differentiate between that, it is S2 that will help you or assist you. I have now evaluated the lungs of this patient. When I am doing auscultation over the lungs, the bad news is I am hearing sound that is crackles or crepitations. That means that initially in this person, the heart failure findings are now started to evolve, and these fine crepitations will be as if you're trying to open a Velcro tape. These bilateral fine crepitations will initially be heard on the lung basis, infraaxillary areas, but as the pulmonary edema component will worsen, you will be able to auscultate them in the remaining lung fields as well. So considering the worst possible scenario that this guy is having a possible MI, I have advised my technician to do a ECG, and the moment I saw the printout, I knew that this is a ST elevation MI, and the ST elevation was 3 millimeter, and I was noted by me in lead number V1 to V4, also in lead number 1 and AVL. So I knew right away that I'm dealing with a case of anterior wall STEMI. I have now decided to do cardiac biomarkers in this person. When I evaluated the cardiac biomarkers, I checked for value of troponin I. Lots of time in government hospital, trop I may not be available, so you can do CPK-MB or trop T as well. The point is, lots of time trop I report might take a few hours to come. Like if you draw a sample right now, the report might come after 3 hours, 4 hours. The point is, I'm not going to wait for the report or trop I to come and then start treating my patient, because if ECG is positive, I know I have a diagnosis right away. In my case, however, luckily the report did come on time and it is showing a definitive doubling. So the words that I wrote on the case file for this patient was admitted a patient with anterior wall STEMI. Now I have to take care of the treatment part of this patient, and that's where the question will be given to you. I mean, the question can be 3 or 4 lines where they will talk about all these findings. He is basically trying to tell you that you have to evolve this. I mean, this word will not be written in the question. The ECG will be given, along with that the theoretical data would be given, and he expects you that in about 30 to 45 seconds, maybe 1 minute, you can work out this diagnosis, and then the treatment part is the one that is usually asked. So on my subsequent slide, I'm going to explain to you what am I going to do for management of this patient. And all of you have read in your medical school this mnemonic by the name of MOON. Well, MOON would imply morphine, oxygen, aspirin and nitrates. Now this is only a mnemonic. In actuality, we don't start with morphine right away. From the ECG are anyway aware it is a case of ST elevation MI, but because of the pulmonary edema component, because of the breathlessness component, I need to give oxygen. This oxygen can be given with help of a nasal cannula, or you can give it with help of a non-rebreather mask, depending upon whatever is the oxygen saturation. And now I will be asking my medic to give to this person a chewable tablet of aspirin. I'm not talking about the 75 milligram tablet, the baby aspirin that I was talking about initially in acute coronary syndrome topic, initially when I talked about chronic stable angina, or patients who are susceptible to ACS. They are the patients of chronic stable angina. In them, to prevent MI, we give 75 milligram. But at the moment, I would be asking my medic to give to this patient a chewable tablet of 300 milligram aspirin. And I also want to tell you that let me say that this is not only the treatment inside the hospital. Even if a medic is calling you from the ambulance, the ECG facility can be present in the ambulance. So he can just take a picture of the ECG and send it to you on WhatsApp or any other social media. So you can definitely see the ECG and ask the medic to give this treatment right in the ambulance itself. Even, in fact, it can be given even at home also. And the message here is that the absorption via the buccal mucosa is what I'm looking for at this point of time, because I know that aspirin will inhibit the production of thromboxane A to inhibit platelet aggregation, as you know from pharmacology, and this will reduce the chances of clot propagation. Along with aspirin 300 milligram, it is also advised according to the current guidelines to also give clopidogrel to the patient. The dose would still be 300 milligrams. Well, how does clopidogrel act? It acts by inhibiting platelet aggregation, by actually inhibiting these receptors, the name of which I have taught you at the moment, and you are aware from pharmac also, that is P2Y12 inhibitors. The concept is of dual antiplatelet therapy. At the moment, for all cases of MI, whether it is ST elevation MI, whether it is non-ST elevation MI, I repeat once again, whether it is ST elevation, whether it is non-ST elevation MI, we recommend dual antiplatelet therapy. And you will hear me talking about dual antiplatelet therapy again in neurology section when I talk about transient ischemic attack. So these are two scenarios when you use dual antiplatelet therapy. I repeat the fact once again, both varieties of MI and transient ischemic attack, which can definitely evolve into stroke. The objective is to reduce the clot propagation. I mean, the bad news is already there's a thrombus formation, but the more the thrombus will increase, more viable myocardium will undergo necrosis. So I'm in a damage control mode at the moment. The mnemonic is written as MOAN, but we don't start with morphine. We give oxygen, we give chewable aspirin to the patient. And now our objective would be to reduce the chest pain. And to reduce the chest pain, I will be first giving to the patient sublingual nitroglycerin. Instead of sublingual nitroglycerin, if I have a buccal spray available of nitroglycerin, all the way better. Why? Because buccal spray can cover more surface area. As a result of it, the result will be relatively better. You can be using nitroglycerin, or dosages are not asked. That is just for your general convenience. That would be 0.4 milligrams. And you can definitely repeat the tablet at a gap of approximately 5 minutes. So let me say on admission, the maximum number of tablets that I'll be giving to the patient would be 3 over a span of 15 minutes. The second tablet is obviously to be given if there's no improvement of chest pain or improvement in the general condition of the patient with the first dosage. And whenever you are writing nitrates for your patient, always be careful about the blood pressure values. If on admission, and I would suggest you to take the blood pressure value by yourself, because lots of time, nurses might be either too casual or they might be overworked, that they may not check the blood pressure properly. They might give you any random value. On the other hand, the BP of the person was reduced and you gave nitrates. The BP will crash, person can die. Please remember the fact that nitrates are absolutely contraindicated. In case the systolic blood pressure on admission is less than 80 millimeters of mercury. In fact, one of the clinical scenarios that you always need to remember where there's a possibility of hypotension is inferior wall MI. In inferior wall MI, it is the right coronary artery that will be affected. So therefore, the right ventricle will not be able to function properly. If right will not function properly, it will send less blood to lungs. If less blood will go into the lungs, less will come to the left side. The message is the two sides of the heart are coupled together. In inferior wall MI, if right ventricle is not going to be able to send proper amount of blood into the lungs and especially to the left hand side, then the left side will also malfunction and therefore the BP of the patient will begin to reduce. Please appreciate the fact hypotension can not only be seen in left ventricular failure. You see, even a non-medical can understand, or let me say somebody with even a 12th background can understand left ventricle determines the cardiac output. So if left will fail, hypotension. You as technical people have to realize that even right ventricular failure or right ventricular malfunction will cause less blood to go to lungs and therefore BP can fall even in inferior wall MI. In fact, in my case that I gave you, I taught you rather about a clinical scenario where the blood pressure was elevated. So rather thankfully, my patient would be safe with nitroglycerin. But as I said, always check the BP values by yourself in a case of MI or suspected MI. And if the blood pressure is on the lower side, that is less than 80, hold nitrates. Lots of time it has happened. This mishap has occurred that blood pressure was very low. Patient was a case of inferior wall MI, and the nurse, even without your permission, because you see, it's not that the nurse is trying to be smart. She was trying to assist you because she has seen you asking to give nitrates to almost every case of MI. She thought that she will assist you, and because you said MI or she heard you saying MI, she thought, okay, let me give nitrates just to assist the doctor. But the point is, once the BP crashes, it will be very difficult to revive this patient in which there's a cardiac malfunction. So do remember this fact. Do not give nitrates in inferior wall MI. In fact, that's an MCQ statement. Nitrates are contraindicated in. The answer is inferior wall MI. And then obviously I can give morphine. Now the advantage of morphine administration is that you can be giving it subcutaneous, you can give it intramuscular, you can give it intravenous as well. And well, availability of morphine is obviously a dilemma, and there might be a possibility that morphine may not be available. Now, why are we giving morphine to the person? It is not that it is a painkiller. Yes, it is a painkiller. I agree to that. Obviously, pain will cause a lot of problems for the patient. So I want to reduce the pain component. But there are so many painkillers, no? Why only morphine? Please remember, one of the important reasons, like even in a medical college exam, no, they ask you, why do you give morphine in MI? The first answer is not that it is a painkiller. I repeat the fact once again, it is not that it is a painkiller. The first reason why we give morphine is because if you read pharmacology, the textbook says morphine causes, listen to my words very carefully, morphine causes shunting of blood from pulmonary to systemic circuit. I repeat the fact once again, morphine causes shunting of blood from pulmonary to systemic circuit. What basically that means is it reduces the pulmonary edema component, because that is what is killing the patient. Apart from this, morphine can also reduce oxygen consumption of the heart. You see, anything that will reduce oxygen consumption is welcome, because already the heart is under a lot of stress. Studies have shown that morphine can definitely reduce the infarct size, and morphine does have a vagotonic action as well. In fact, there are multiple actions of morphine that I've said at the moment. That is going to be reduction of pulmonary edema, reduction of oxygen consumption, reduction of infarct size, and vagotonic action. And when I talk about vagotonic action, I want to highlight that in a patient of MI with bradycardia, inferior wall MI can have a tendency for bradycardia. So if a MI patient is having bradycardia, then hold morphine. Do not give if the heart rate of the patient is less than 60. In our case, however, the patient is safe with this drug. Why? Because I give you a scenario where heart rate was anyway elevated, but you definitely need to keep in mind the vagotonic action of morphine, by which obviously it will conserve oxygen consumption, but at the same time with the bradycardia, it is not advisable. The fifth drug is again to be given very carefully, that is metoprolol. You see, metoprolol single dose is recommended for all cases of MI on admission, because initially when person will come, especially early, heart failure findings may not be present. So in those circumstances, since acute congestive heart failure findings may not have fully evolved or may not have developed at the moment, so I am safe to give metoprolol to the patient. In fact, why am I giving metoprolol is, again, it reduces infarct size. How? By reducing the heart rate. See, if you reduce the heart rate, you are downgrading the oxygen consumption of the heart. If you downgrade the oxygen consumption, you can salvage more myocardium. So the point is, whenever metoprolol is given, it tends to reduce the size of infarct. In fact, both morphine and metoprolol have been documented to cause a substantial reduction. Single dose metoprolol I'm talking about has been shown to cause a substantial reduction in mortality and infarct size. Now the point is, if somebody is already having bradycardia, then do not give metoprolol to the patient. If it is symptomatic bradycardia, you need to give atropine. I want you to remember that in inferior wall MI, it is the right ventricle that is damaged, and vagus nerve innervation occurs in the right ventricular wall. In fact, vagus nerve innervates the heart at three areas. You are aware from physiology, so I'm just saying it. Vagus nerve innervates the heart at SA node, vagus nerve innervates at AV node, and even in the right ventricular wall. This is the site where vagus would be innervating. So if there is damage to the right ventricle wall, vagus will be irritated. I'm just putting a plus here to say vagus is getting irritated in inferior wall MI, because right ventricle is suffering from ischemia, and the irritation of the vagus nerve will contribute to bradycardia. In fact, this is itself an MCQ. Which MI will have bradycardia? Answer is inferior wall MI, and therefore in this person BP will be relatively less. Jugular venous pressure will anyway be elevated because right ventricle is malfunctioning. The moment you look at the vitals in a multiple choice question, if he talks about bradycardia, hypotension, elevated JVP, the moment he says bradycardia, you should be thinking, where should I look in the ECG? Is it not an inferior wall MI? You should look at lead number 2, 3 AVF. On the other hand, if you get a question in which he is mentioned regarding what I just said initially, tachycardia with this finding, there's a tachycardia, increased blood pressure, and elevated JVP. This is usually a feature that can be seen in initial presentation of anterior wall MI thanks to sympathomimetic stimulation, and there is no or minimal vagal nerve innervation in the left ventricle. So by looking at the vitals and the aspects of the heart sounds, a lot of information becomes relatively clear. And from this discussion, I have also sensitized you to the fact that metoprolol is contraindicated in a patient of inferior wall MI. In fact, at this junction, you know two drugs which are contraindicated in inferior wall MI, which are those nitrates. Why? Because BP is low. And why don't you use beta blocker? Because heart rate is low. I repeat once again, because heart rate is low, I'm not comfortable giving metoprolol. Because BP is relatively low, less than 80, I'm not comfortable giving nitrates. So two drugs that I was praising initially for management of a STEMI case is valid for anterior MI. In inferior MI, I would not like to use it. Rather, for bradycardia component, I would like to highlight. If he says, what will you use for bradycardia component in inferior MI? You would be using for symptomatic bradycardia atropine, or you can be using TCP, transcutaneous pacing. For hypotension, you will give IV fluids. Please remember, you don't give IV fluids in any variety of MI. You don't give IV fluids in any variety of MI. That is anterior MI. You never give IV fluids because pulmonary edema is there. But in inferior MI, there cannot be pulmonary edema. Why? Because right ventricle is failing. So you are safe to give IV fluids. Guys, this is itself a question. Which MI can you give IV fluids? The answer is inferior MI. You cannot give IV fluids in anterior myocardial infarction. So the drugs part obviously has to be stronger. The next drug that I shall be using for my patient will be enoxaparin. The advantage of using this drug would be that it will reduce the clot propagation. If enoxaparin is not available, I can obviously use plain heparin as well, that is UFH or unfractionated heparin. But overall, I would say enoxaparin is more comfortable to use because of once a day daily usage. And next, my patient could be having pulmonary edema. I would like to repeat the fact that in inferior MI, there will be no pulmonary edema present. Pulmonary edema is always a feature of left ventricular failure, so it would be seen with anterior MI. So this treatment that I'm writing at the moment is for a person who's having an anterior ST elevation MI. I would be giving furosemide, which is a loop diuretic that will reduce the water as well as the salt load in the body and thereby reduce the load on the heart and improve the compliance. I can also be using ACE inhibitors. Well, ACE inhibitors can be given orally if the condition of the patient will permit, but to test a pharmacology, the examiner can ask you regarding a intravenously used ACE inhibitor. Well, I'm very sure you are comfortable with this from your pharmacological knowledge as well. That is enalaprilat, not enalapril. Enalaprilat would be the format that can be given intravenously. And if person is still having pulmonary edema, I can still be using nitroglycerin drip also, because it will be a venodilator as well as an arteriodilator, so it will reduce both the preload as well as the afterload component in the patient. Now, my objective is to take up this person in the cath lab. The treatment of choice for any patient who's suffering from ST elevation MI is a primary percutaneous coronary intervention, which would ideally be done within 90 minutes of patient turning up in the hospital. The door to balloon time is 90 minutes or lesser. This is what I'm saying. I'm going to take up this patient in the cath lab and we are going to take a vascular access. It could either be a transradial access, it could be a transfemoral access, depending on the convenience, or I would say the expertise of the interventional cardiologist. And now we will be doing a coronary angiography of this person. On the monitor, the coronary angiography report will actually tell you in real time which coronary artery is obstructed. Though from ECG you very well know that, but you will notice now there will be no flow of dye in the left anterior descending artery because there's a thrombus occluding it. So we need to bust this, we need to destroy it, and therefore the procedure done in this case would be balloon angioplasty. Yes, the same procedure that was done in case of our former captain Saurav Ganguly. He was working out on a treadmill in his house when he started having this heaviness in his chest. Initially he thought that it is some kind of indigestion. He thought initially it could be just some mild illness, and unfortunately the chest pain became very oppressive, so he had to be rushed to the hospital where ECG showed a particular ST elevation and he had to undergo this procedure of balloon angioplasty. The MCQ answer for treatment of choice for STEMI, ST elevation MI, is primary percutaneous coronary intervention. And as I highlighted earlier, but for record's sake, I'm having to write it down also. This is an important statement. In fact, I would rate whatever I'm writing at the moment as the most important information with respect to treatment of ST elevation MI. The door to balloon time should be kept under 90 minutes. Well, if you do not have facility of cath lab in your hospital, let me say, or cath lab is not functional in the late evening hours. So I'm just giving a scenario to you that cath lab facility has shut down in the evening hours or is not available. Then what are you gonna do? For treatment of ST elevation MI, if cath lab facility is not available, whatsoever be the reasons, administrative logistics, thrombolysis is then to be done. And here the guidelines are door to needle time. Like if the patient enters into the door of my hospital right now, I should be done with ECG, biomarkers, basic stabilization with the drugs that I was teaching you, and I should start thrombolysis within 30 minutes of arrival of the patient to the hospital. Now there are multiple drugs available for thrombolysis, and we'll talk about each one of these as we progress in our discussion. Most of the time we will be using L-Taplis, though it is obviously expensive in government hospitals. Lots of time L-Taplis may not be available, so you will be using streptokinase for the patient. Other options which are available but are expensive and are used in corporate setup are like Retaplis or Tenectaplis. The advantages of using Retaplis and Tenectaplis is that they can be given in a bolus format, whereas L-Taplis streptokinase are mainly given in the form of an infusion. So the good old streptokinase will anyway work, but on a comparative basis, L-Taplis is written first in the textbook mainly because of the complications being relatively lesser. So if in the exam you have to select a single best answer, I would suggest you to answer L-Taplis as is given in the textbook, and he can obviously ask you how will these drugs act, because they would love to incorporate pharmacology component in internal medicine as well. So the mechanism of action will be production of plasmin. And what will this plasmin do? It will dissolve the clot. It is called as a clot buster drug. Why? Because it will convert fibrin insoluble. You see, the clot is not fibrinogen, it is fibrin insoluble. So the drug will basically convert this fibrin insoluble into fibrin soluble by generating plasmin. That's the universal action of all of these. And then he can obviously ask you about the big side effect that could be occurring with this drug. And that is a serious side effect, guys. It could be development of intracranial bleeding. I highlight the fact once again, whenever you are giving thrombolysis to a person, careful monitoring of the patient should be done for any neurological findings. Like if one side pupil begins to dilate, it means probably he is having a CNS bleed occurring. So you should always be vigilant all through the infusion of thrombolytic. Yes, they are safe drugs, but at the same time, there is a possibility of complication also, so that complication should definitely be kept in mind. If you have to give single best answer should be given as L-Taplis. I'll tell you a couple of problems with streptokinase which will make you relatively more comfortable with this, and I would also like to highlight that streptokinase can be associated with anaphylaxis. First of all, though this is not given in notes, I just want you to remember the dose. I mean, you can listen to this part. The important part I'll ask you remember or make you remember. 1.5 million units is the dose of streptokinase which is to be given, and this is to be diluted in 5% dextrose in water. The infusion time will be over 60 minutes. Now let us have an administrative issue here that the shift of the nurse is ending, and she thought that, okay, why to give orders to the next shift, let me just run the drip fast. I wrote a proper instruction of these many drops per minute over 60 minutes, but she ran the drip faster and the drip went over 30 minutes. So they can definitely be, I mean, if you infuse a drug faster than what you actually tended to or intended to, there's a possibility of a brain hemorrhage occurring. And therefore the point to be noted down is, what is the antidote for streptokinase toxicity? You see, like you study regarding warfarin toxicity, you study about heparin toxicity and antidotes for it. The question said, what is the antidote for streptokinase toxicity? Yes, the antidote you are very well aware from pharmacology, that is ECA, that is epsilon aminocaproic acid. I want you to remember that if he says a person is having warfarin toxicity and there is a CNS bleed occurring in the patient, then for CNS bleed we can be using either PCC, that is prothrombin complex concentrates, or fresh frozen plasma. For heparin you are very much familiar about protamine sulfate, but yes, I definitely want you to be comfortable with streptokinase toxicity as well. Now, streptokinase is isolated from this bacteria Streptococcus. There are various subtypes of it. Like you are aware, group A, beta hemolytic Streptococcus, that causes rheumatic fever. Group B is the one that could be present in female genital tract and could contribute to neonatal meningitis. I want you to remember, group C Streptococcus is the one from which streptokinase is isolated. In fact, here they have even asked in the exam the strain of Streptococcus from which streptokinase is isolated, and your answer is Streptococcus equisimilis. I repeat the fact once again, a tongue-twisting name. Streptococcus equisimilis is the bacteria from which streptokinase is isolated, and because we as humans are exposed to this bacteria so many times in our life, as a result of it, there is a distinct possibility of even anaphylaxis risk. Anaphylaxis risk is not seen with the remaining drugs, but yes, anaphylaxis risk is very much present with respect to streptokinase, and how to reduce it. In fact, I can give you a clinical scenario that will make you more comfortable to understand the anaphylactic component. You see, this person has already received streptokinase, let me say in the month of July 2020. And this person had a next episode of MI, maybe let me say in December 2020 or maybe in January, then there's a distinct possibility that when he came for the second time, he was not carrying his papers, as most people in India, when they come to the hospital, they may not be carrying their previous medical records, and there's no digitization of records in our country. So there's a distinct possibility that because either you did not ask it or the patient was not carrying the records, you gave streptokinase again for the next episode of MI that occurred in the patient. And first time also he was given streptokinase, now also streptokinase, so anaphylaxis will definitely occur. The guidelines are, because considering the anaphylaxis risk, the guidelines given in the textbook is reuse of streptokinase should always be done with caution, and at least 6 months should have elapsed. 6 months should have passed by, and after that streptokinase can be reused. Why? Because then by that time the antibodies would have been cleared by the immunological system of the patient. The message is streptokinase, because of the risk of anaphylaxis, it is advisable that you use L-teplase, with which the risk of anaphylaxis will be very negligible or very minimal. So even if you are reusing it after 1 month or 2 months or 3 months, absolutely no problems, you can be pretty safe. In fact, at this juncture, I would like to dedicate a few minutes into talking about anaphylaxis also, because this is extensively asked in the exam. They have asked what is the cause of death in anaphylaxis. Options were like hypotension and laryngeal edema, laryngeal spasm, and I found a couple of doctors casually answering this as laryngeal spasm, whereas the actual cause of death is laryngeal edema. Please remember that it is histamine that is involved, obviously the inflammatory mediators I'll talk about, but the end result is laryngeal edema, and therefore you need to give antidote also. Next, I shall be giving the antidote for anaphylactic shock, and you're very well aware of that you have to give adrenaline to the patient, that is epinephrine. The dose can be about 0.5 to 1 milligram, and well, this would be given intramuscularly. Why not intravenously? Because of release of histamine, the veins will dilate, and therefore you may not be able to visualize the veins properly, and you might just keep on trying to cannulate the vein but might fail to get a vascular access on account of hypotension. The veins are collapsing. As a result of it, the textbook says give it intramuscularly, just jab it in anywhere, even if the person is wearing clothes, because lots of time in winter season, person might be wearing a sweater, etc. So you may not be getting a proper muscle access right away. You might have to cut the clothes of the patient, and even if scissors is not available, you can jab it through the clothes also. This would be 1:1000 dilution. Please remember the fact that in cardiac arrest it is always 1:10,000. It's always diluted. The only scenario, I repeat the fact once again, the only scenario where we give undiluted adrenaline is for anaphylactic shock. For cardiac arrest it is always a diluted adrenaline that would be given. Apart from this, they have asked about the cytokine which is involved in anaphylaxis, that is interleukin 4. They've asked which cell mediates anaphylaxis. Options were like eosinophil, basophil, lymphocytes, neutrophil. Lymphocyte, neutrophil you can rule out, but then between eosinophil and basophil, I found lot of guys casually answering eosinophil mediated. No guys, it is basophil mediated. You can refer to the pathology book for this. It's not a routine allergy, right? We talk about anaphylaxis, which is a notch above the allergy component that we study. Then the test that we will be doing in the patient, do not answer urinary histamine or serum histamine levels or serotonin levels. Rather, the test that is done subsequently to demonstrate that yes, it was anaphylactic shock, because nowadays is a scenario of evidence-based medicine. So you need to demonstrate that the person had an anaphylactic shock or anaphylaxis. So the test would be done as serum tryptase levels, and the antidote I've already sensitized you to. And please do not answer laryngospasm. See, when it comes to laryngospasm, the condition or MCQ where you will answer laryngospasm as a cause of death is tetany. I've described this in endocrinology segment as well. If the serum calcium of a person is less than 7 mg/%, then tetany tends to occur, and this can kill a person due to laryngospasm. In all MCQs of tetany, the cardiac link is that calcium and QT interval have an inverse relation. So if calcium will become less, then QT will become relatively prolonged. So in lots of cardiology MCQs, MCQs in which, I mean, they're trying to incorporate cardiology in a question of tetany. QT prolongation will always be given, and you will be giving 10% calcium gluconate to the patient. So once we are through with this anaphylaxis risk, I want you once again to go through this fact that whenever we are treating a person of ST elevation MI, the treatment of choice is primary PCI, but if the facilities are not available, definitely thrombolysis can be done. And now I'm going to create a scenario before you where thrombolysis has been done successfully, and then I'm going to create a scenario where thrombolysis was done unsuccessfully, or I can say failure of thrombolysis. So please be patient while I just make a couple of sketches before you. This was the ECG of the patient when I started the thrombolysis. ST elevation was close to about 3 millimeter. This I'm just writing 0 minute to highlight that this is when thrombolysis was being given in the patient, or thrombolysis was towards its end. Now in the same patient, after half an hour when thrombolysis drip has finished, I noticed that the ST elevation has become relatively lesser. So I decided to repeat the ECG another time, and I noticed that now the ST elevation has become even relatively lesser. So the time zones that I mentioned are 0 minute, 60 minutes, 90 minutes. This 0 minute, I would like you to be very clear, is not from entry into the hospital. This is like when I started the drip, or I like lots of time L-tablets, re-tablets, they can be given in the form of a bolus also. So especially when re-tablets is given in the form of a bolus, the moment re-tablets is over, you can actually do a baseline ECG, and then I've repeated it after 60 minutes of completion of re-tablets, L-tablets, whatever drug I have given, and then repeated it in 90 minutes, and you can notice the fact that the ST elevation of the patient is definitely showing a declining trend. The ST elevation has gone down from 3 millimeter to 2 to 1.5 millimeter, 1 millimeter. So this diagram basically wants to explain to you that I have been able to do a successful thrombolysis of the person. Now let's do this activity again. You have right now started streptokinase / L-tablase, re-tablase, whatever is available in the hospital. This was the initial ECG of the person. Now the drip has finished. You repeated the ECG after 1 hour, but you found that the ST elevation is still the same. So you thought, okay, fine, let me wait for a while, and you repeated the ECG again at 90 minutes from wherever the drip had ended, and you noticed that the ST elevation is still very much present. Now you are very perplexed, because normally whenever you evaluate or whenever you treat a person, the ST elevation should show a declining trend. That means that there is a successful thrombolysis. But in this case, the bad news is that the ST elevation is persisting. So first I wanted to give you evidence of what I mean by the word failed thrombolysis. I mean, since I do not, or I am not doing angiography, so I need some indirect evidence, no, whether coronary artery is opened or not. So the evidence that I'm having at the moment is that the ST elevation is almost the same, or might have been even on an increasing trend, because if you don't open up the artery, then the necrosis in the heart will be progressive. So the message is, if ST elevation is going to be persistent in spite of thrombolysis, it indicates the fact that your thrombolysis does not work. Now in this scenario, what are you going to do? You are gonna take up the patient in the cath lab, and because I said, like, suppose you're practicing at a smaller hospital where cath lab facility is not available, then you are in a big fix, because you will have to transfer him personally in an ambulance to a specialized hospital which has a cath lab facility, and you are supposed to do a rescue PCI in the person. Well, what did you learn here? You learned here the fact that rescue PCI is an alternative term or a different term from what I was initially mentioning before you as primary percutaneous coronary intervention. You need to understand the difference. In any case of ST elevation MI, the main treatment is primary PCI, because we do it right away. It is a primary PCI. But when do you do a rescue PCI? Failed thrombolysis. So the message is, from the MCQ statement, I want you to, or from MCQ perspective, I want you to remember this words that I'm writing. If ST elevation persists, and the cutoff that you need to take here is 90 minutes once again, but this 90 minutes that I have taken, see, I mentioned 3 time zones here, that is 0 minute, 60 minute, 90 minute. I wanted to remember the 0 minute that I'm calculating here is not from entry into the hospital. He has already been admitted, already the treatment has been started. This is when the thrombolysis in the patient was started. Let me say, re-tablets can be given very fast, so over 2 minutes only. So at the end of that, I can repeat an ECG. Like I did a ECG when thrombolysis is, drip is being started, one towards the end, and then subsequent at 60 minutes, and then at 90 minutes. So what I am saying is 90 minutes he has already spent in the hospital. Thrombolysis is already over and still ST elevation persists. So the message is, if ST elevation and even the chest pain of the patient might be persistent, but chest pain is not a reliable criteria, no, because you're trying to suppress it using morphine. So ST elevation persists even 90 minutes from thrombolysis infusion. Please remember this statement very carefully, because I have seen very brilliant people making mistake between a primary PCI and a rescue PCI. Primary PCI is when you do it right away, but in this case we first tried a thrombolysis now. Since the thrombolysis was not successful, and how did you know it is not successful? Because the ST elevation is persisting or might be showing an increasing trend as well. So this statement is important. ST elevation persists 90 minutes from thrombolysis infusion. That is when you would be going in for rescue percutaneous coronary intervention. And just to hammer this point once again, we'll practice the aspects that I've just taught you in the previous slide, so that you are able to retain this permanently. I'm gonna say it in a flowchart format. First is, you are dealing with a case of STEMI. Cath lab facility plus means it is available. Cath lab negative implies that the facility is not available due to whatsoever be the reasons, far away or the doctor is not available. Facility is there, but the interventional cardiologist is far away, and maybe he is reached back home when the case came. So by the time you call in the interventional cardiologist, it will be very, very late. So let's look at what are you gonna do. If cath lab facility is available, take the patient up after giving the baseline treatment that I explained to you, and do a coronary angiography, see whichever blood vessel is blocked, and in real time evidence, just destroy the thrombus deploying a balloon, that is balloon angioplasty. And I gave an example of Saurav Ganguly. He is hale and hearty, is perfectly doing fine. Now, when it comes to primary percutaneous coronary intervention, the objective is that if person enters into the door of my hospital right now, then within 90 minutes of entry into the hospital, I should be able to do this procedure. But if the cath lab facility is not available, no issues. I will be deciding right away. We will be starting thrombolysis of the patient. Depending upon whichever drug is available, D to N means door to needle time, which should be kept under 30 minutes. I have started thrombolysis in my patient, and I expected that ST elevation should definitely come down, but unfortunately it is failing to come down. There's a persistent ST elevation present in the person, so I will have to refer him to a cath lab equipped hospital, or I have to ensure that the interventional cardiologist comes now. So in those circumstances, we will now be doing what is called as rescue percutaneous coronary intervention. And as I've already explained to you, rescue is going to be done with 90 minutes, not from entry into the hospital, but from thrombolysis infusion. See, thrombolysis infusion for retaplace will take a very short duration. Thrombolysis infusion for streptokinase is going to take a little longer. So the message is that once you have started thrombolysis, you need to monitor the patient on a regular basis to see whether he's improving clinically. Clinically, you can pick up in the form of relief of chest pain, the general well-being of the patient, oxygen saturation, blood pressure values, crepitations in the chest. But in my patient, there is no hemodynamic improvement. And at the same time, even ECG is not showing an improvement. So that is when I have done a decision to go in for rescue percutaneous coronary intervention. The cutoff for both is 90 minutes. But please remember, for primary, it is from entry into the hospital. And for the right-hand side, that is rescue PCI, it is from the thrombolysis infusion by the time it is usually completed. So this is an important flowchart that I would definitely love you to practice by yourself, so that you are able to remember the facts and deliver them when they're actually required. Next, I shall be explaining to you regarding contraindications for thrombolysis, and the first and the foremost to be remembered is recent stroke. Let us assume this patient had 2 months ago a brain hemorrhage due to hypertension, which was uncontrolled, and now he has had a ST elevation MI episode for which I'm doing a thrombolysis. Then there's definitely a risk that during the current thrombolysis which is being done in the patient, he might actually have a rebleed in the same area which he had a bleed 2 months back in the brain, or maybe at a new site. So recent stroke, we definitely need to be a little careful, and especially if it has occurred in the previous 3 months, then we should not be doing thrombolysis in the person, and rather preferring a percutaneous coronary intervention. The point number 2 that I'm writing is relatively easy for anybody to pick up in an MCQ, because the moment he says bleeding diathesis, it's relatively an easy pickup. I can just give an example. Let us assume a person is having chronic ITP and his platelet count is less than 1 lakh. Then the chances of CNS bleed will be relatively higher. So in those circumstances, I would like to raise the platelets by maybe, if required, a platelet transfusion as well for a short term. And thereby, once the platelet count will stabilize, then subsequently I can give thrombolysis. Similarly, prothrombin time is deranged or activated partial thromboplastin time is deranged. We need to get them back to normal. Like let us take a example here, though this has been said multiple times by me earlier also. A patient is having warfarin toxicity and the prothrombin time is grossly elevated. Let me say 20 times or normal or 15 times or normal. In such gross elevations of prothrombin time, I can be giving prothrombin complex concentrate to the patient. If not available, I can be using fresh frozen plasma, and this would obviously take a little bit of time, but the point is once you neutralize the warfarin toxicity, then the person's coagulogram report will come back to normal and thrombolysis can be safely done. Point number 3, I thromboplastin time is deranged. We need to get them back to normal. Like let us take a example here, though this has been said multiple times by me earlier also. A patient is having warfarin toxicity and the prothrombin time is grossly elevated. Let me say 20 times or normal or 15 times or normal. In such gross elevations of prothrombin time, I can be giving prothrombin complex concentrate to the patient. If not available, I can be using fresh frozen plasma, and this would obviously take a little bit of time, but the point is once you neutralize the warfarin toxicity, then the person's coagulogram report will come back to normal and thrombolysis can be safely done. Point number 3, I usually find people neglecting it. So let's have a look at this. Though it has been already told to you, but I've seen students neglecting it. That is, in unstable angina, the clot is already fragmented. If you're going to fragment it further into further smaller pieces, it will not cause any improvement. It will rather cause mayhem. It will worsen the patient. Unstable angina was discussed in acute coronary syndrome part 1, where it was highlighted that thrombolysis is contraindicated. And the same thing is what I've said at the moment once again. And same is the case for even Prince metal angina. I've just used a short form. PA implies Prince metal angina. There is a spasm of the coronary artery, and spasm cannot be treated with thrombolytic drugs. For Prince metal angina, we shall be using calcium channel blockers. We can be using nitrates for symptomatic relief. For point number 4, I want you to remember a person is having aortic dissection. Now, aortic dissection can travel antegradely or it can travel retrogradely. If it is going to be a retrograde spread, it can result in coronary artery dissection. And if there's a coronary artery dissection, that's again a type 1 MI, but we are not going to do thrombolysis because for a tear in the coronary artery, nothing is possible. See, aortic dissection can be managed surgically, but not a coronary artery dissection. Most of the time, the person will die. Then, if a person is having substantially elevated blood pressure, he says first to reduce the blood pressure. That will take up a couple of minutes and then you can thrombolyze. The cutoff I want you to remember for the exam is systolic more than 185 and diastolic more than 110. He says first try to stabilize the blood pressure using drugs like labetalol, or we can use nicardipine, and once the blood pressure is stabilized, then subsequently thrombolysis can definitely be done. If a person has received prolonged CPR, brain dies within 4 minutes of cessation of circulation. If somebody has received prolonged CPR, the definition is CPR has been given for almost 10 minutes or more. That means that irreversible damage to the vital organ, especially brain, has occurred. So trying to survive or trying to increase the survival of this patient is just going to prolong the agony of the patient as well as of the relatives as well. So there is no survival benefit that you are achieving by this case. So is the scenario with respect to pregnancy. Now I would like to mention that this is a relative contraindication in a sense that you will notice that suppose when I'm talking about this is a broader perspective, guys. Why I'm saying relative is like, let us assume a lady, because thrombolysis can be done in acute ischemic stroke also, and thrombolysis will be discussed in the topic of even stroke. So I want to be clear here about the fact that suppose a pregnant lady, she is 34 weeks pregnant and she had a stroke. Now, should I do thrombolysis in her if she comes in the window period, which is 4.5 hours for acute ischemic stroke? Yes, I should do a thrombolysis, because see, if she will develop neurological deficit, then she will not be able to take care of herself and she cannot take care of the baby. Like suppose a lady has a hemiplegia, she cannot be expected to breastfeed the child or take care of the basic requirements of the child like changing a diaper, etc. So here I'm giving you a broader perspective to understand the thrombolysis is not only done in ST elevation MI, it is done in acute ischemic stroke as well. I said window period for treatment of acute ischemic stroke is 4.5 hours from the onset of symptoms. If a pregnant lady comes within that time frame, I definitely can do thrombolysis for acute ischemic stroke, or if she's had an MI and if I have to do it in a dramatic fashion, I will try to save the life of the mother. But otherwise, if alternative strategy is available, like I'm saying a pregnant lady had a MI, unfortunately, if I have a safer alternative in the form of PCI, I will prefer a primary percutaneous coronary intervention. So I've just put the word relative here. For point number 8, 9, 10, again, I want you to listen with care, though they can be picked up in the question. Like, suppose we have a known case of brain tumor and this person is having a MI. Now he says that when you will treat this person, the MI will definitely get cured. The thrombolytic drugs will definitely show their effect, but they could be bleeding in the brain tumor tissue and therefore brain herniation can occur. Now try explaining that to the relatives of the person. Like, okay, we are going to treat the coronary heart disease problem, but your patient can die because of brain hemorrhage. They will outrightly refuse to give consent for such kind of a procedure because as I highlighted, first to no any harm to the person. So you cannot justify opening a coronary artery and causing a brain hemorrhage in an individual. And same is the case even for point number 9. KCO means known case of arteriovenous malformation. He has a large berry aneurysm. You know this berry aneurysm can rupture at any point of time. Then yeah, I would not be very comfortable doing thrombolysis because brain hemorrhage, once it occurs, it would be potentially catastrophic here because there's already a sinus malformation. Similarly, if a person has got a recent major vascular surgery done, like a person was having a large aortic aneurysm, I've already taught you that if the aortic aneurysm is more than 5.5 centimeter in the abdominal aorta, it can rupture spontaneously. So if a person has had a recent major vascular surgery done, then in those circumstances, again, thrombolysis is contraindicated. Ideally, you should be knowing all of this, but at least the top 4 that I've highlighted is relatively easier to comprehend, or I usually find these being asked in the exam, though they can ask anything, but these are the common ones that I have usually seen being asked. So recent stroke, bleeding diathesis, unstable angina, I've definitely did a ink change there deliberately so that you can remember this fact, Prince metal angina and aortic dissection. And in aortic dissection, I highlighted it could be a retrograde spread. Now once you are through with the thrombolysis part, I will now discuss the case once again of the same patient that I initially explained. My patient was a 60-year-old gentleman who was a known case of hypertension. He is having chest pain for 3 to 4 hours. So it's the same patient. The only difference will be in the ECG per se, that the ECG of the patient is not showing a ST elevation, but it is rather showing a T wave inversion only. There's no ST segment changes. So now I'm gonna change the case to that of non-ST elevation MI. I have written the word same patient just to highlight everything that I said earlier. The auscultatory findings are the same. The only thing is that when we evaluated the ECG, the ST was perfectly normal, and in lead number V1 to V4, I found was only a T wave inversion present. In these circumstances, the diagnosis of the patient would be kept as non-ST elevation MI. I've also requested a troponin I report as early as possible. Luckily, it was available on time and it is showing a doubling. But this time, the clinical diagnosis will be kept as NSTMI of the anterior wall. And now's the time for treatment. So I will be teaching you a mnemonic for non-ST elevation myocardial infarction. Well, the mnemonic can be remembered as ABE MOON. MOON you are already familiar with, that is morphine, oxygen, aspirin, nitrates. I did explain that in ST elevation MI. Alphabet A here would stand for epsiximab, that will control the platelets from misbehaving any further. They've already caused substantial damage and caused a thrombus in the coronary artery of the patient. Alphabet B would stand for beta blocker, that is metoprolol, which will reduce the mortality by decreasing the heart rate and will reduce the infarct size. Alphabet E would stand for enoxaparin, that's low molecular weight heparin to prevent clot propagation, and morphine, oxygen, aspirin, nitrates is what I've already talked about. So this is the initial treatment which is to be given for all patients of non-ST elevation MI. Now I will monitor my patient in the following fashion. I will check for the general status, the general well-being, the SpO2 values, the blood pressure values, and the crepitations, and I'm going to create a bad situation here. Bad in the sense that his SpO2 is not improving in spite of all the maneuvers that we have done. Supplemental oxygen is being given, the drug treatment has been given, and rather when he came, the blood pressure was recordable. Now it's going towards 80/60. When he came, the creps were very minimal or were hardly held, but now they have become louder or they become loudest. So the severity of crepitations has increased, severity of pulmonary edema has increased. This tells me that my patient is not responding to treatment. So what should I do if my patient is not showing response to ABE MOON? Then I need to take up the patient in the cath lab once again, and this time the procedure that will be done will again be balloon angioplasty, will destroy the thrombus in the coronary artery, but we are going to call it a a delayed percutaneous coronary intervention. If you're listening to me carefully, in ST elevation MI, I taught you regarding a primary PCI and a rescue PCI for failed thrombolysis, but now I'm teaching you delayed PCI for non-ST elevation MI, and most of the time in the exam, they basically try to, mention these terms and try to fox you, but I am very sure if you have listened carefully, there will be absolutely no issues, because primary PCI and rescue PCI is for ST elevation MI. Rescue, as the name suggests in English, is for failure of thrombolysis. I've drawn before you what I mean by the word failure of thrombolysis. The ST elevation is persistent, and especially when it's going to be a non-ST elevation MI patient not responding on vitals perspective, on clinical perspective, then yes, delayed percutaneous coronary intervention is to be used. PCI was introduced the first time for chronic stable angina, where I talked about PCI with stenting. I talked about single vessel disease, double vessel disease. Then PCI came in ST elevation MI, two varieties. I repeat once again, primary and rescue. And for non-ST elevation MI, it is delayed PCI. So the data is very straightforward. And let's just see whether you have been able to follow me or not. So try to make this table while I'm writing this information, and we'll try to do it preferably under 1 minute. Just note down these three details: ST elevation MI, non-ST elevation MI, and unstable angina. Make a table like this, and the topic we're studying is acute coronary syndrome, which can have these three differentials. Our objective will be to remember or pick them up in the multiple choice question, because he's not going to say the word stem I, he's just going to give you ECG finding and troponin I values. Trop I is showing a doubling, and ST elevation is obviously present in ST elevation MI. The doubling of trop I is present in non-ST elevation MI also, but ST is either normal or can be having a depression. And in unstable angina, the values can be normal or they can be slightly elevated to the level that might be below the threshold of detection. So that's why in lots of MCQs, values of ST elevation, or rather I would say the ST values would be given as normal or depressed, whatever be the case, but troponin I values will be given as normal. I repeat once again, why they're given normal is because though yes, perforators are blocked, so that is why some amount of necrosis is occurring, but that necrosis amount is limited, so the detection of whatever kit that you're using, the problem is of the kit per se, that it is not able to have a proper sensitivity. So the values of unstable angina will be in troponin I values in unstable angina can be normal. Now, once I have differentiated between these three conditions, it would be, he would ask me the next best treatment. So for ST elevation myocardial infarction, the main treatment is primary percutaneous coronary intervention. However, if the primary PCI facility is not available, it is streptokinase, and I've already sensitized you to that. If streptokinase or any thrombolytic drug is not available, we will do a rescue PCI. However, for the extreme right hand side, two of these data that I've said, non-ST elevation MI and unstable angina, the treatment is common. Please note down that unstable angina and non-ST elevation MI are written as slash in the textbook. Why they're written unstable angina / non-ST elevation MI is because in both of them the ST findings are identical. No, ST in both of them can either be normal or can show a depression along with T-wave inversion. What is the difference between the two? Difference is in the value biomarkers. The value biomarkers in unstable angina will usually be normal to mild elevation, maybe below the threshold. But in MI, when I say the word MI, I have always said elevated cardiac biomarkers, so it will definitely be grossly elevated. So most of the time in the textbook it is written as UA / non-ST elevation MI. The initial treatment for both of them is same. Please appreciate the fact that in real clinical practice, lots of doctors will not even try to differentiate between the two, because they say that our objective is treatment, and treatment for both of them is same. So why do we? This is the academic class, so that is why we are trying to do this differentiation. But otherwise, I said in clinical practice, nobody would like to waste their time, because ECG finding is same and trop I only is different from mathematical perspective. So if AB mone will fail in the person, then we will take up the patient in the cath lab once again and do a delayed percutaneous coronary intervention. If you can make this table faster, though, since I had to explain, it took me a little more than a minute, but if you can just quickly draw this table, it would solve you the hassle of remembering the information or cramming up the information. And I also want you to remember at this junction that if they say what is the best drug for management of non-ST elevation MI, if they say what is the drug of choice for unstable angina, then for both unstable angina and non-ST elevation MI, it is nitroglycerin drip. If nitroglycerin drip is not given in the options, then you can also answer enoxaparin. There are three situations where IV nitroglycerin is the drug of choice. It is unstable angina, non-ST elevation MI, and Prince metal angina. And do remember the fact that if IV nitroglycerin is not given, I'll just highlight this information here. I said N is to be answered as the drug of choice for UA/non-ST elevation MI, but suppose nitrates is not given, then the next best answer, the answer is based on which drug will have maximum reduction in mortality. So they've done comparison of various drugs and said which contributes how much to reduction in mortality. It is nitrates and enoxaparin. Why nitrates first? Because they are going to reduce the load on the heart. They would be causing a coronary vasodilation. So obviously the chances of survival will be faster if you start nitroglycerin right away in the scenarios. And also one interesting information came up here. The interesting information that came up here was that all these three conditions that I have now marked out before you, all these three are contraindications for thrombolysis, no? Unstable angina, Prince metal angina. I'll just show that slide once again. Contraindications to thrombolysis. You can see I had highlighted this. UA, non-ST elevation MI, and Prince metal angina are contraindications to thrombolysis. And in all the three conditions, the drug of choice is IV nitroglycerin. However, if IV nitroglycerin is not given, then for unstable angina and non-ST elevation MI, only for these two, the second best answer is enoxaparin. And for Prince metal angina, I've already told you, it is calcium channel blockers. See, in Prince metal angina, there's a spasm, no? So for acute episode, you will give nitroglycerin, chest pain is gone. Patient is saying, sir, I want to go back home. You'll say, no discharge today. We are going to monitor you for any possibility of arrhythmias. And then subsequently, since hypoxia was there, I need to monitor for possibility of arrhythmias. Now, next day when I'm discharging the patient, I'm going to put this person on amlodipine to prevent the vasospastic episodes that occur in Prince metal angina, maybe early morning on the next and subsequent days. So do get these data in the right perspective, because I'm giving you first best answers and second best answers. So you, lot of you do message me or ping me subsequently, sir, what is the single best answer? Whatever I say first is the single best answer. But lots of time, there is a possibility that two drugs might be contributing identically to reduction in mortality. That is why I have to mention even two answers sometime. So this table is, however, important, guys. I would rate it as one of the important information for this particular topic. And if you get this right, then the perspective of yours would be perfectly fine. As far as Prince metal angina is concerned, I have not included this in the table at the moment, because per se, when I talk about acute coronary syndrome, then acute coronary syndrome will incorporate the following aspects only. When it comes to Prince metal angina, I have already explained to you that there would be ST elevation present. Only angina with ST elevation is Prince metal angina, and the biomarkers will be normal. Well, why? Because spasm cannot cause necrosis. Necrosis can be possible only in the scenarios that I've written, and in unstable angina, I said because small blood vessels are involved, the necrosis may not be detected. But in Prince metal angina, there is absolutely no necrosis in the heart. Please remember this fact. Prince metal angina, there is no necrosis. It is only a vasospasm present. And gender-wise, Prince metal angina will be more common in female patients, and also right coronary artery is more commonly involved for Prince metal angina as compared to left-sided circulation. Whereas all the events that I've explained to you, in whether it is MI, non-ST elevation MI, unstable angina, I've always included male patient, and I've always highlighted that left side of the heart is mainly involved, because I was giving you anterior MI examples. But the message is for Prince metal angina, it could be the right side of the heart that might be involved more. And well, where do you scan for the right side of the heart in the ECG? It is lead number 2, 3 and AVF. So in a Prince metal angina MCQ, lead number 2, 3 AVF can be having ST elevation, but biomarkers are normal. You repeated the biomarkers again after 3 hours, after 6 hours. Maybe you thought, okay, maybe this report is not accurate, so you got it done from a different place, and still the values are stuck there. That's the scenario of Prince metal angina. There is no need for provocative testing for Prince metal angina, as I've explained to you, and these are the three important differentials which are to be remembered for acute coronary syndrome per se. We shall now be discussing regarding complications of myocardial infarction. I want you to remember that the commonest complication is not congestive heart failure, as a lot of doctors tend to answer. Rather, the number one that I'm going to teach you is arrhythmias, and they can be fairly lethal. Both brady as well as tachyarrhythmias can occur, and patient can even expire on the way to the hospital or maybe right on arrival to the hospital. One of the tachyarrhythmias which will be fairly lethal is ventricular fibrillation. Second can be bradyarrhythmia that he can ask you, and that's going to be movements to heart block. In fact, it can be given as a case-based scenario to you where he will explain somebody who came to you with chest pain at rest, having lot of sweating and all the features that I explained. And considering the grave situation of the person, you allocated a bed for the person. You told the patient, okay, please lie down at this particular bed and I'm going to get an ECG of yours done and we'll draw a blood sample and initiate your treatment. So the patient was taken on a wheelchair. We did not even make him walk, was taken on a wheelchair to a particular bed. ECG was being done, or let me say the ECG reporting was already completed, or maybe somebody was drawing the blood sample of this person when suddenly he collapsed, or maybe his daughter suddenly started crying, and I was attending to a different patient. So in the casualty, when somebody is crying, you'll obviously go and have a look. So I went to the bedside of this guy. I had seen this guy about 10 minutes ago and had instructed my technician for an ECG. And now this guy's daughter is crying suddenly. So I found the guy was lifeless in a sense that his lips were blue and there was no heart sounds. There was no pulse. Well, what really happened was either of the two. Either it could be a tachyarrhythmia or it could be a bradyarrhythmia. And prevalence wise, you will always notice that ventricular fibrillation incidence is more common than that of movements to heart block. In fact, because these problems can occur in the first hour, so lots of time in multiple choice questions, you might read about this word golden period for myocardial infarction is first hour. Why? Because if the person reaches the hospital on time, then at least you can do defibrillation. You can give DC shock to the patient to terminate this arrhythmia. And if it is movements to heart block, you can try initially atropine and then go in for TCP, that is transcutaneous pacer or transvenous pacer. So the message here is that sudden cardiac death, whenever he gives you a scenario of a person suffering from an acute coronary event, either dying in the hospital or in the ambulance or maybe even at home, then either of the two possibilities should always be kept in mind. Now, as far as ventricular fibrillation is concerned, it is relatively easy to pick up. You would be noticing this twitching that is occurring around the baseline in all 12 out of 12 leads. And once this ventricular fibrillation starts, we need to obviously go in for defibrillation in the patient. Lots of time when he will give you this scenario, he will explain that the person was admitted with acute chest pain and the person is in the premises of the hospital and now he has become pulseless. So he will say what is to be done in the patient. Like options could be like check pulse, give CPR, go in for defibrillation. Obviously defibrillation is the treatment of choice for ventricular fibrillation, but he's asking you what will you do first? Would you straight away defibrillate? Would you first check the pulse of the patient, or would you first give CPR? Now the point that I want to make here is that don't answer check pulse here, because person is already in the hospital and ECG at the moment is already running. See, do not confuse this with what I was discussing in basic life support, that if somebody will collapse suddenly and will become pulseless and is not breathing at all, in those circumstances, yeah, I mean, if I want to demonstrate that somebody is pulseless, I need to check the pulse. But in this case, if ECG is showing this rhythm, patient will anyway be pulseless. You will waste some precious seconds trying to find out a pulse which is anyway gonna be missing. So in these circumstances, if the question says what is first to be done, your answer is CPR, and then you will definitely hook him up to a AED, that is automated external defibrillator, and you will be delivering a DC shock to the heart of this guy, which may be, if given at the right time, that is as early as possible, might be able to get the rhythm back to normal. The intensity of DC shock that would be given in this case would be 200 joules biphasic, and this DC shock will always be non-synchronized. The difference between synchronized and non-synchronized DC shock has already been explained, but I would just like to refresh your memory. Synchronized basically means that the impulse is fired by the computer at the peak of the R wave. In this case, there is no R wave that is visualized. It is just twitching present all over the baseline, as a result of which the computer will get confused, and to resolve the confusion of the computer, we are rather going in for random firing, that is non-synchronized DC shock. The message is that whenever we use the word synchronized DC shock, it is called as cardioversion, and whenever we use the word non-synchronized DC shock, it is referred to as defibrillation. So the treatment of choice for this patient, agreed, is defibrillation, but first step for this particular guy in the hospital premises is not. I'll just highlight this fact that the tendency of most of us is whenever we read about a pulseless patient, we definitely want to check or talk about the steps of CPR, but in this case, since the person is already in the premises of the hospital, so this would be a waste of time, and you would rather like to dedicate those precious seconds in giving CPR to this individual. I would like to highlight that if a doctor comes after 5 minutes minutes, then the chances of return of spontaneous circulation will definitely be reduced. The treatment of choice remains whatever is going to be same, whether you come after 5 minutes, whether you arrive in the first 5 minutes, that is defibrillation. But as I said, ROSC, that is return of spontaneous circulation, chances will definitely be reduced as more and more time elapses. So CPR must be initiated in the person very fast, and that is at a rate of 30:2, that is 30 chest compressions and then 2 rescue breaths. They have also asked that one cycle of CPR will last for minimum duration of how many minutes. So I hope you can recall that one duration should be lasting for at least, or one cycle of CPR should be done for at least 2 minutes. At the same time, I would also like you to remember that the number of DC shocks that can be given to the patient is a total of 3. In fact, I would suggest you to listen to the basic BLS, the basic life support, and the ACLS component of lectures which are given in the emergency medicine just below the cardiology section to make you more comfortable. And you will also notice that during the management of a ventricular fibrillation patient, I have also talked about usage of adrenaline with respect to the second DC shock. Well, most of the queries that I get is, sir, why are we giving adrenaline in a guy with ventricular fibrillation? It is understandable if somebody is having cardiac arrest, if it is a flat line in the ECG, we give adrenaline to stimulate the SA node. But why are we giving adrenaline at this junction? Well, why are we giving adrenaline at this junction is not to stimulate the heart or maybe get the activity of the SA node back. The SA node may be working at the moment. It is multiple ectopic foci in the ventricles which are causing twitching. What I want to do here is, by giving adrenaline, I am trying to increase coronary perfusion, and the moment I increase the coronary perfusion, the hypoxia will reduce, and hypoxia is the villain which is responsible for this problem, no? After all, MI causes hypoxia. You are trying to neutralize the hypoxia component. So the reason why we use adrenaline in cardiac arrest or flatline ECG is to stimulate the SA node and get the cardiac activity back to normal. But in this case, our objective is to enhance the coronary perfusion. Also, I want you to remember that there is absolutely no role of atropine. Now listen to these words very carefully. Atropine is definitely given in symptomatic bradycardia, but we do not use atropine for routine resuscitation. In fact, when I was a student at your age, I used to study regarding use of atropine in CPR and then subsequently ACLS and basic life support. But now they have demonstrated that atropine has no mortality benefit, so it is discontinued when it comes to management of patients who are become suddenly pulseless and BP-less, and so is vasopressin. In 2010 guidelines, vasopressin was definitely there. For 2015 guidelines, vasopressin role was mentioned as plus minus. So even in, you see, the guidelines come every 5 years. So even in MCQs of 2018-19, you will notice, if you have ever used the older version of my book or any other book per se, you will notice that in the older versions of the textbooks, vasopressin role was still defined. It was written plus minus, but the role was defined at least that it will cause a reduction in mortality. But the current guidelines have categorically demonstrated, 2021s, that there is absolutely no mortality benefit with respect to these two drugs. So obviously, I mean, in an MCQ, these drugs are not to be answered. Also remember the fact that when you're giving CPR to an individual, then there are a couple of important questions that should be remembered. One, they have asked that what is the commonest solid organ traumatized during CPR? The point is, CPR would be given on the lower 1/3 of the sternum, and well, if a doctor has not marked his site properly, if he presses too low, he might be pressing on Xiphi sternum, and Xiphi sternum is very pointed, so it might actually tear into the left lobe of the liver. So solid organ traumatized during CPR is not to be answered as lung, because lung anyway is not a solid organ. I agree that ribs can break, but the point is, it is not lung that is the commonest solid organ traumatized during CPR. It is rather going to be answered by you as the liver. And I said the villain behind this, the bony prominence which is responsible for this, is Xiphi sternum, because the doctor has not marked a site properly or is not properly practiced on the dummy. At the same time, they have also asked which is the rib which is commonly fractured in CPR. So though any rib can break, but 4 to 6 ribs, why 4 to 6 ribs are more liable to actually crack or break, is because they are at an angle. So angulated ribs are having more susceptibility to actually get fractured. But suppose he says that the rib is fractured, what will you do? So even if the rib fracture occurs, you are not going to discontinue CPR. The CPR activity will definitely continue, and it would be better that somebody who's more trained than you takes over the activity. But the message is that when it comes to children, then the ratio of CPR will change. In fact, I'll just highlight the guidelines for adults first and then compare this with children, because they gave a scenario like this, that a child put his finger in an electrical socket. Now, you're very well aware, like if a child gets electrocuted, arrhythmia can occur, and that is ventricular fibrillation. And he said, you are the only doctor on duty. If you are the only doctor on duty, then the resuscitation ratios of chest compressions, rescue breaths will remain the same. But if it is two doctors on duty, then the ratio will not be 30:2, then it will be 15:2. I want to highlight this fact once again. When it comes to rescuers and an adult patient, whether it is one doctor on duty, whether it is two doctors on duty or three doctors on duty, it does not matter. The resuscitation rate would still be 30:2. But when it comes to a child, if you are a single rescuer versus two rescuers, the answer will vary. And when it comes to neonatal resuscitation, please remember it is mandatory to have two rescuers present, and the ratio would be 3:1. So I have seen people making silly mistakes like answering 3:1 for children also, whereas for children it is same as that for adults if you are the only doctor on duty. As far as the depth of sternum going down, sternal depression is concerned, for adults, it is about 5 centimeters. So they always say push hard and push fast. But when it comes to a child, the sternal depression will be 2 centimeters. For newborn, it is 1 centimeter. For neonatal resuscitation, you can encircle the chest of the baby and press with your thumb, or you can use your fingers. You can learn that from pediatrics. But when it comes to adult, you have to be very clear. And a method of giving chest compressions has been discussed in basic life support by me, so you can go there. But then this is an important, I would say, ready reckoner that I would like you to remember. And from the exam perspective, this is the point. Right, single rescuer versus two rescuers, which can definitely cause an error of judgment. So in any case of ventricular fibrillation in a casualty, you don't have to check pulse if already ECG is showing you a ventricular fibrillation. I mean, that's how you're documenting it. You straight away start CPR and proceed with defibrillation in the patient. Unfortunately, though I have treated my patient after 12 hours, though arrhythmias can occur at any point of time after MI, after 12 hours, ventricular tachycardia incidence is found to be substantially increased. So let us now see what is going to be the ECG finding in VT and what are we going to do for it. I am first at the moment showing normal. So luckily we have ensured that our patient has come back to normal sinus rhythm, and now he's in the recovery unit in the coronary care unit, and there is broad QRS complexes occurring again and again. You can notice that the RR interval has dramatically reduced. I mean, if you compare the RR interval what was initially and compare with the RR interval now, the RR interval is reduced, means the tachycardia component is coming up. And as this arrhythmia will pick up speed, you might be having the classical Josephson sign, which is a shelf in the downswing of the S that I've highlighted. In fact, sometimes they might even give you a rabbitier appearance with the Josephson sign. And well, as the person will deteriorate, then subsequently you will get a classical sinusoidal pattern of a monomorphic ventricular tachycardia. And I personally feel that VT is again very easy to identify because of these aspects that I've sent. The arrow that I'm putting up here is for Josephson sign. There is a intermyocyte conduction occurring in this case, so therefore you might be having even this rabbit ear appearance. And a rabbit ear appearance in this case is not going to be symmetrical, in a sense that one ear of the rabbit is relatively bigger than the other. On the extreme right hand side, the sinusoidal pattern can be seen. Definition of ventricular tachycardia is more than 3 premature ventricular complexes. Where I put the star mark are the premature ventricular complexes. You can see broad QRS complexes, and the RR interval of the patient is reduced. So I'm writing broad QRS tachycardia is one of the important diagnostic features of VT. And in this case also, if he mentions the word patient has become pulseless, then I'm not gonna go in for drugs. Then I straight away need to go in for DC shock, and that would be again a non-synchronized one. In fact, 2 scenarios where we go for non-synchronized DC shock is one for patient who is having ventricular fibrillation, second is pulseless ventricular tachycardia. The intensity remains the same, 200 joules biphasic. All models are programmed for it. From the drug of choice, perspective of ventricular tachycardia, see how he will trouble you. If he just says the word, what is the drug of choice for stable ventricular tachycardia? The answer is amiodarone. But if he gives you a scenario for ventricular tachycardia, post myocardial infarction, and mentions that the patient is hemodynamically stable, mark my words there. If it is a collapse, if crashing of the blood pressure, it's obviously a DC shock, it's a defibrillation which is to be done. But if he mentions post MI, patient is stable at the moment, then the answer should be given as lignocaine. So this minor difference should be remembered, because see, VT can occur even without MI. VT can occur even in severe metabolic acidosis cases, because acidosis can be damaging the myocardium and can trigger an arrhythmia. So the answers will vary upon the situation given, and this is an important point that I've just highlighted. Post MI VT, if the patient is hemodynamically stable, lignocaine, otherwise defibrillation would be done in the patient. So tachyarrhythmias can definitely be lethal, and for bradyarrhythmia, I would like you to refer to ECG and arrhythmias component. The first complication that is seen in any case of MI is arrhythmias. This can cause death on arrival to the hospital, or maybe during transport, or maybe even at home. Now my next statement is that patient has already been admitted with you for 6 hours, 8 hours, or let me say even 24 hours, and still he died. So the relatives are definitely going to ask you, or the MCQ will ask you, why does a patient of MI die after admission? You have done everything possible for the guy. PCI was done or thrombolysis was done depending on the facility. If you've done everything, still the person is dying. Well, one of the important reasons why this can be happening now, unfortunately, is cardiogenic shock, because there was substantial myocardial damage. See, the size of the infarct can be really big when it comes to extensive anterior wall MI, where the left main coronary artery of the patient is blocked. So if a person has sustained severe myocardial damage, he will undergo, or he will develop cardiogenic shock. And for cardiogenic shock, you need to obviously use drugs which can help the person recover. Now, what are the drugs to be answered here? So I usually see a lot of doctors very casually answering dobutamine. Yes, we do use dobutamine, but we don't use it initially. If the BP is tremendously reduced, or mostly cardiogenic shock will have an unrecordable BP. So first we will use norepinephrine. Why? Because norepinephrine mainly increases diastolic blood pressure. Listen to the words very carefully. When norepinephrine increases diastolic blood pressure, what is the advantage? It will increase coronary perfusion, because you know from physiology that coronary blood flow occurs mainly during diastole. So if you increase the diastolic blood pressure, coronary perfusion will improve, and therefore the myocardium now is getting more fuel, so it will pump better. Norepinephrine is the first drug to be answered for management of cardiogenic shock, not dobutamine. And one of the reasons why I am mentioning dobutamine inferiorly or lower down is because dobutamine will directly stimulate the heart and increase the heart rate. Imagine if you increase the heart rate right now, you are putting more stress on the heart. The poor fellow is not being able to work. And now you're gonna be trying to cause more stimulation and increase the heart rate, so person can actually deteriorate. So first we let the BP stabilize up to 100 or so. That is when dobutamine can subsequently be used. So you will notice norepinephrine, dopamine, and dobutamine in that order you are supposed to answer. And what does dopamine do? One advantage is it activates D1 receptors in the kidney and increases glomerular filtration rate. That's very important, because that will prevent renal failure. Lots of patients with MI might develop cardiogenic shock and might go into multi-organ failure. Why multi-organ? Because heart is also failing and then kidneys are also failing. So oliguria and anuria can occur in a person. Now to test you, he can also mention a refractory cardiogenic shock, which implies that you have already used these drugs, but unfortunately the BP is not picking up, the pulmonary edema is still very much present. So you will now have to deploy some devices. Interventional cardiologist has been called on the scene, and now you will be going in for what we can call as percutaneous mechanical support. In percutaneous mechanical support, we can put a device that will support the function of the left ventricle, that is Impella. And in fact, Impella has more superiority over IABP, that is intra-aortic balloon pump. In fact, most guys feel more comfortable with this word balloon pump, but let me just explain what it means. This intra-aortic balloon pump actually exhibits counter pulsation. What I mean by counter pulsation is that balloon of the IABP does not inflate during systole, it inflates during diastole. Why? Because when it will inflate during diastole in the aorta, it will send more blood into the coronaries. I said counter pulsation. So when the heart is relaxing, that is when the balloon is working, and when the heart is contracting, right? At that point of time, there is no coronary blood flow. So counter pulsation. Why? Because when the heart is relaxing, that is when the balloon is contracting. So these are anyway percutaneously deployed external battery powered devices that will take over the function of the heart. And usage, or I would say Impella, has shown a better survival chances as compared to intra-aortic balloon pump. Though a lot of questions may not mention Impella, so IABP is okay as an answer for refractory cardiogenic shock. The learning is that if a person is having cardiogenic shock, first use drugs, then use percutaneous devices, and if these are not available or if the damage is substantial, then person we may not be able to save also. For the next complication, I'll just draw a diagram before you, so please be patient while I just try to sketch this. This is the representation of the myocardium, which is undergoing a substantial amount of necrosis. So my patient at the moment is having a full thickness infarction. So lots of time you will read words like subendocardial infarction, transmural infarction, full thickness infarction. My patient is undergoing a full thickness infarction. Let us see what happens. I have now modified the diagram to say that there is a through and through necrosis. You see the outermost layer of the heart, which is pericardium, will obviously try to limit the blood flowing into the chest cavity. I'm not saying that the blood will spill over into the chest cavity, but you can very well see in this case that if there's a through and through rupture, the blood of the patient will accumulate in the pericardial sac. Now, pericardial sac is supposed to have maximum 20 to 50 ml of fluid for lubrication purposes. This diagram is showing patient's own blood. Patient's own blood filling up in the pericardial sac very rapidly and crushing the heart from outside. Yes, guys, I'm talking about cardiac tamponade. The cardiac tamponade issue, the problem here is that the external pressure, the pericardial space that I've represented, where I have put these dotted blue lines, the pericardial space pressure has substantially increased. It's crushing the heart from outside. So therefore, the filling of the heart will also be compromised. And if less will come in, less will go out. So most patients will become pulseless and BP-less. I have once again explained a scenario to you where a post-MI patient is becoming pulseless and BP-less, but this time there is no tachyarrhythmia or bradyarrhythmia. So what really happened here? What really happened was a through and through rupture of the heart. But to make it sound sophisticated in the MCQ, he's not going to write the word rupture of the heart following a transmural MI. To make it sound sophisticated, he will write this word electromechanical dissociation. EMD, or electromechanical dissociation, implies patient is becoming pulseless and BP-less. Why? Because the heart is going to just burst like a balloon and all the blood will spill over into the pericardial space, and this is going to crush the heart from outside. The problem in electromechanical dissociation is that of cardiac tamponade. Now, how as you as a physician, as a doctor will come to know this is cardiac tamponade is by evaluating the ECG of the person. So when I sketch the ECG, you will notice that I will try to show electrical alternates. I'm not showing any problem with the duration of the QRS complex, but I'm definitely showing a variation in the voltage generated with respect to the QRS complex. And please be patient so that I can just draw a few complexes here. You will notice that as such, the duration component is fine, but the amplitude of QRS complex is definitely changing. This is what I'm saying. You can notice that the amplitude of QRS complex is having a beat to beat variation because the heart is now dancing in a bag of blood. The swishing action, the heart is beating in a bag of blood. So the voltage gradient is changing, and this has been described even in diseases of the pericardium. The ECG finding is called as electrical alternates. So whenever he is describing post-MI patient having electrical alternates, what is your thought process? The heart has burst like a balloon. The pericardial space is filled with blood. There's going to be swishing action of the heart. It's trying to work. The person is nearing his last few minutes of his life, and well, nothing can be done for this guy. You see, there is no role of DC shock for this pulseless patient. So DC shock is absolutely contraindicated in a person of electromechanical dissociation. There are two scenarios where DC shock is absolutely contraindicated. One is what we have just discussed right now, that is electromechanical dissociation, and second is asystole. There is absolutely no point of giving DC shock to a person who is having a flatline ECG, because for flatline ECG you need to actually give adrenaline to stimulate the heart. There is absolutely no point of giving DC shock on a flatline ECG. And now a non-shockable rhythm that I've explained to you is electromechanical dissociation. In fact, this electromechanical dissociation word should not be confused with AV dissociation, because AV dissociation means atrial and ventricle firing frequency is different. Atria are doing 100, ventricles are doing 40, complete heart block. Atria is doing 100, ventricles are doing 200, ventricular tachycardia. AV dissociation is read with respect to bradyarrhythmia, complete heart block, tachyarrhythmia, ventricular tachycardia. But at the moment, the word is not a AV dissociation, EMD, electromechanical dissociation. I would also like to mention some accessory information before we go ahead from the ECG component. This time I'm going to show you variation in the amplitude of broad QRS complex. You can see that the QRS complex is becoming bigger and smaller. So the variation is with respect to a broad QRS, because last time what I showed you was variation in normal duration QRS. Amplitude is variable here, but the duration, the QRS duration per se in the ECG that I've sketched at the moment is perfectly normal. But if you compare this with the subsequent ECG, you will notice that there is definitely a variation. But this variation is of the amplitude of not a normal duration QRS. It is variation of amplitude of a broad QRS. This is going to be seen with Torsades de Pointes, that is polymorphic ventricular tachycardia. Let's do one more variation. Please be patient while I sketch this before you. I will also be showing a irregular RR interval in this one. The size of the P wave will also be changing. So you are noticing at this particular junction that the RR interval is not constant. In fact, at this juncture, one of the foremost things is RR interval is changing. That's always a feature of either atrial fibrillation or multifocal atrial tachycardia. Why I'm saying multifocal atrial tachycardia here is because the height of the P wave every time has been shown to be different. This particular ECG that I made before you, MAT, multifocal atrial tachycardia, is also having a variation. But variation is in what? It is in the amplitude of the P wave. So I've taught you 3 ECGs where there can be variation present. Let's just quickly revise them. If you get a ECG in the exam in which the variation is in normal duration QRS complex, and especially it's a post-MI patient, you have to think in terms of through and through rupture of the heart. Just remember the line diagram that I made here, cardiac tamponade. The technical, just to make it sound sophisticated, he will use the word EMD. But if you read about variation, this time the variation was with respect to normal duration QRS, variation of broad QRS. It is polymorphic ventricular tachycardia. And if you're going to be having a variation for the P wave, that is MAT, multifocal atrial tachycardia, that can be seen in patients of COPD most of the time. In fact, MAT has been extensively asked in AIMS, currently referred as INISET per se. So I want you to go through the lecture of multifocal atrial tachycardia also subsequently, so that you're more comfortable with the topic. My next patient, however, is not so lucky. He had a subendocardial infarction. So in this guy, what I am trying to show is that luckily there was not through and through rupture of the heart, but you can see that some part of the ventricle is bulging out like a balloon. Last time there was a through and through rupture. This time what I have simply shown is that some part of the heart is bulging out in the form of a balloon. So the complication that I'm describing at point number 4 is LV aneurysm. Let me just recall or recap for you. I've taught you arrhythmias, cardiogenic shock, and then electromechanical dissociation. Next person is having a LV aneurysm. Well, what is the problem with LV aneurysm is contractility, because this part of the heart will not be able to contribute to the power generation. So therefore, especially in this part of the heart that is bulging out, there's going to be stasis. Stasis would definitely bring in clots, and if clots will develop in this area, if any one of them goes into systemic circulation, this guy has had it, he can develop hemiplegia, quadriplegia, speech deficits, because he will develop embolic stroke. I have taught in neurology that the number one cause of embolic stroke is non-rheumatic atrial fibrillation, but now I'm teaching you another cause of embolic stroke, left ventricular aneurysm. How would a doctor come to know that the person is having a LV aneurysm? There are two ways of knowing it, and obviously the best way is echocardiography. If I do a bedside echo, you see, most of the time in post MI patients, you will notice that on the second day or third day, we do anyway a bedside echo. So this is a very reliable way to pick up a LV aneurysm which is developing. But to test your knowledge, he can obviously ask you a ECG finding also, and the ECG finding of even left ventricular aneurysm is a persistent ST elevation. Now, there are two reasons why you could be having a persistent ST elevation. One can be failure of thrombolysis that I've explained earlier. But suppose person has hemodynamically improved. You have done thrombolysis, there is a hemodynamic improvement, but still there is a ST elevation present. That implies it could be a LV aneurysm that is developing. I repeat the fact once again. There are two causes why you could be having a persistent ST elevation. One is failure of thrombolysis. But if you are having a hemodynamic improvement after doing a thrombolysis, the general well-being of the patient is better, the chest pain is not there, and blood pressure is stabilized, pulmonary edema has gradually resolved. So if person is improving and still there is a ST elevation, the possibilities are that he might be in the phase of development of a LV aneurysm. So do remember this phrase, persistent ST elevation can be found in LV aneurysm too. Once I've identified it, I need to start treatment because anyway he can develop embolic stroke. So I will be starting this person on a combination of heparin plus warfarin. You very well know the fact that warfarin may not be able to exert its effect immediately. In fact, the effects of warfarin will usually take about 5 days to occur. So I would like to give bridge with heparin. I can be using a low molecular weight heparin subcutaneously, and after 5 days, I'm just putting cross into 5 days, I will discontinue heparin in the patient, but warfarin will continue. I repeat the fact once again because the effects of warfarin will take some time to appear. So I will give bridging or cover with heparin. Heparin will start working immediately, and once after 5 days, I have given substantial time for warfarin to act. So now I will discontinue heparin and continue with warfarin in this person, and this warfarin will be continued on a lifelong basis. Now, when I say lifelong basis, patient will definitely ask me, or relatives will ask me, sir, are you serious? I mean, lifelong? I said, yeah, that is our primary goal. And if required, if there's a gradual improvement, maybe in the contractility, if we find in subsequent scans, the cardiac activity is better, yeah, we might discontinue. But initial objective is that we want to minimize the chances of stroke. Assuming that it's a big aneurysm, lifelong warfarin is being given in this guy. So there is always a possibility of intracranial hemorrhage risk because lots of time the chemist might change the brand. Never change the brand of whatever warfarin you have given to the patient because every brand might be having a different bioavailability, and lots of time the chemist might give a double dose tablet to the patient that might actually cause brain hemorrhage also. So you need to warn the patient, and you will tell the patient that every time you come to me for a consultation, especially if he's on warfarin, you need to actually be on or at least get this blood test done every time you see me. That is prothrombin time or international normalized ratio. This is itself a question that what monitoring should be done in patients on warfarin on long-term basis. It is prothrombin time and international normalized ratio. And since this is obviously tedious, so you always have the facility of using NOAC also, that is novel oral anticoagulants. The drugs are like rivaroxaban and dabigatran. NOAC I have also described in management of atrial fibrillation. I have described NOAC, novel oral anticoagulants, even with atrial flutter, so you can read them there. The message is NOAC will have lesser chances of intracranial hemorrhage. So this tedious process of getting a prothrombin time or INR monitoring done on a regular basis will be relatively lesser, or I would say usually not required. The message is wherever possible, if cost is not a consideration, I've written warfarin because obviously rivaroxaban and dabigatran are expensive. The message is where cost is not a consideration, always give NOAC, even in a case of LV aneurysm. But if obviously like in poor patients in our country, well, they may not be able to afford medicines from outside and you have to give everything from government supply. So warfarin is definitely available and can be given to these patients. The subsequent complication of myocardial infarction that I'll be explaining to you is Dressler syndrome, and this complication will occur approximately 3 to 6 weeks after onset of MI. All the previous complications that I've explained to you have occurred either on the same day of myocardial infarction or maybe occurring within 24 hours or maybe few days after a MI episode, but this one is occurring couple of weeks later. So this is a late complication that I'm talking about. This gentleman is experiencing chest pain once again it is present at rest, is diffuse in character, and this guy is wiser this time. Last time he neglected his chest pain for maybe 4 hours, maybe 6 hours, but this time his chest pain has been present for only 2 to 3 hours, and he has decided to come to me relatively earlier as compared to what he did last time. I'm noticing at the moment there is no evidence of any breathlessness, there is no evidence of any pulmonary edema findings per se in the patient. So initially I was wondering, is it a reinfarction or is it Dressler syndrome? So let us now see how will I be able to differentiate. In this guy, on auscultation, I might be getting a special finding because see, when you study pathology, they always teach you about the etiology of Dressler syndrome. Dressler syndrome occurs as a autoimmune pericarditis, and when I say the word pericarditis, that will explain the auscultatory finding that I just mentioned. Pericardial friction rub is what is gonna be heard. Now, when I evaluate the heart sounds of this guy, S1 and S2 will be normal, because if it's gonna be coronary event causing a heart failure, then S2 can either be narrow split or wide split, as I explained to you earlier. But here the heart sounds were fine, and it was just a pericardial friction rub that was present. Therefore, I proceeded with the auscultation of the chest of the person, but there was no evidence of any pulmonary edema. Chest was bilaterally clear. So to be sure about my diagnosis, I decided to do a ECG and biomarkers. When I did ECG, I noticed a very interesting finding of ST elevation, but this ST elevation, however, was not convex. It was concave in upward direction. You can very well see the slight difference in the ST segment elevation that I've shown at the moment. In MI, it is always convex, but in pericarditis, it is always concave. I want you to remember that this ST elevation that is concave in upward direction will be found in all the leads. So he might deliberately ask you except, and your answer will be AVR. You see, in the ECG and the arrhythmia section, I've highlighted AVR. The first wave of the ECG, P wave and T wave are always upside down. So AVR will not be showing a ST elevation. AVR will always be showing a ST depression. That is, a opposite finding will be seen. AVR will be having rather a ST segment depression. Another interesting finding which I have tried to show here is I have deliberately not shown the PR segment. You see, this area is not PR interval. It is end of the P and the starting of the Q wave that I'm highlighting. This is PR segment. So I have shown it in a downsloping fashion to say PR segment depression. I want you to remember that if ST is going up, then PR is going down. This PR segment depression can also be mentioned in the MCQ because this examiner thinks is relatively easy for you to answer. ST elevation concave upwards. So sometimes they might mention PR segment depression in all except the answer would still be AVR because AVR is gonna read the heart the other way around. So P and T are anyway negative, and PR segment, instead of PR segment depression, there it would be PR segment elevation. Whether he mentions ST elevation, whether he says PR segment depression, you would definitely be able to crack the question on the basis of a relatively stable patient with a pericardial friction present with the following ECG findings. And to resolve any controversy, you anyway have to check out the biomarkers which were normal in this patient. In fact, I repeated them after 3 hours again of presentation, and they were again normal. Now, I will tell this guy, don't worry, you are not having a reinfarction, you're not having a MI again. I would put you on medication and you'll be fine. On reading the word autoimmunity, lot of doctors casually answer steroids for treatment of this condition, but I would suggest you not to answer steroids. Why? Because one, steroids can interfere with the healing process. See, he has just recovered from MI. If you give steroids for a few days, they might interfere with the scar, the ultimate strength of the scar. The scar has to be powerful. If you give steroids, there will be impairment of healing and the scar may not be as strong as you want it to be. So rather, you will be giving aspirin to this person. This would be given with obviously Mucain and Digene, etc., so that at least the gastritis component can be handled, and the chest pain of autoimmune pericarditis can be handled by aspirin, and you don't need to use any stronger drugs per se. So this is definitely a MCQ or a case which you have to pick up is a late presentation, but this is not a reinfarction, and you have to differentiate reinfarction by especially looking at the biomarkers component and the ECG finding, and both obviously have to be correlated so that you can come to a final diagnosis. In myocardial infarction, because of ischemia to the papillary muscles, there can even be valvular dysfunction developing in the patient. So he would love to ask you, what is the commonest valvular lesion that is seen post-MI? Well, the commonest valvular lesion that is seen post myocardial infarction is mitral regurgitation. Well, why is mitral regurgitation coming up everywhere, whether you read Libman-Sachs endocarditis, whether you read infective endocarditis, is because mitral valve in our body operates at the highest hemodynamic stress, so it is vulnerable to stress or vulnerable to damage per se. And in fact, he can change the question. He can say which valvular dysfunction is never seen post-MI. I repeat the fact once again. Commonest is MR. Why? Because mitral valve operates at the highest hemodynamic stress, but which is never seen post myocardial infarction. Then the answer should be given as aortic regurgitation. Why that is so? The logic behind that is that aortic valve blood supplies directly from aorta. I repeat the fact once again. Aortic valve blood supplies directly from aorta. So MI is not a disease of aorta, no. MI is a disease of coronary arteries. So even if coronary arteries are affected, this will still continue to get its supply from the aorta per se. So aortic regurgitation is never encountered, and mitral regurgitation is most commonly found. And rarely there's also possibility that interventricular septum might be infarcted, and if that happens, even a VSD can develop. Well, pansystolic murmur is a feature of mitral regurgitation. Pansystolic murmur is also a feature of ventricular septal defect. Ventricular septal defect I've covered even with the congenital heart disease topic as well, but I'm just highlighting the fact that if there's a necrosis of the interventricular septum on the account of the pressure difference, you would definitely be able to see a pansystolic murmur developing in the person. So you could be having structural damage. So point number 6 can be re-identified or re-mentioned as rather a structural damage that can be seen after myocardial infarction. Obviously, the most common one, the rare one, are to be remembered. And do remember these terms in relative sense. You see, there's a difference between the word never seen versus rarely seen, no? If I say never seen, I mean, obviously you can understand the English differences here. So you need to be very careful while answering these questions. And this is structural damage that can be seen after MI. I've described 6 complications after MI. I'll repeat them once again. You can be having arrhythmias. You could be having cardiogenic shock, for which even percutaneous mechanical support would be required. Then can be bursting of the heart. That is electromechanical dissociation. Then can be bulging of the heart outside. That is a LV aneurysm. Dressler syndrome and valvular malfunction /structural damage is the usual complications that are seen. So I've described the topic acute coronary syndrome, which is something that you are not only gonna see as questions in your exam, but even in your clinical practice. Once you get into a GP practice or any practice whatsoever, MI is something which is gonna be inherently present from a perspective of an Indian doctor having to manage the case. Because even if you specialize in something else, if a case comes to your nursing home, comes to your clinic, you should have basic knowledge to manage the pulmonary edema component, stabilize the patient, and let the cardiologist take over. Thank you so much for your patience and hearing me out. And well, keep hammering, guys. Keep learning more and more facts. And as you keep on learning more facts, you will become a more wiser person. Thank you so much.